Hello everyone and welcome. Today we'll be discussing a rare but serious condition affecting the urinary system, ureteral avulsion. Ureteral avulsion, put simply, is a tearing or ripping away of the ureter, the tube that carries urine from the kidney to the bladder from its point of attachment, usually at the ureteropelvic junction, where it connects to the kidney, or at the urerovesical junction, where it connects to the bladder. The most common cause is trauma. This can range from blunt trauma in car accidents or falls to penetrating trauma such as gunshot or stab wounds. Iatrogenic injury, meaning injury caused by a medical procedure, is another significant cause. Surgical procedures near the ureter, such as during abdominal or pelvic surgeries, or even during ureteroscopy for kidney stones, can inadvertently lead to avulsion, especially if adhesions or scarring are present. Rarely, extreme sudden movements or forceful manipulation during certain medical procedures can also contribute. The pathophysiology of ureteral avulsion is straightforward. The ureter is forcefully separated from its attachment point. This disruption in the urinary tract has several consequences. The immediate effect is a complete blockage urine flow from the affected kidney. This leads to hydronephrosis, a buildup of urine in the kidney, causing it to swell. If left untreated, hydronephrosis can cause permanent kidney damage. The avulsion also causes bleeding and inflammation in the surrounding tissues. Urine leakage from the torn ureter leads to a condition called urinoma, a collection of urine outside the urinary tract. This can cause further inflammation, infection, and scar tissue formation. Ureteral avulsion is considered a relatively rare injury. Its exact incidence is difficult to determine because it often occurs alongside other traumatic injuries, masking its presence or making it challenging to isolate in epidemiological studies. However, it's observed more frequently in settings with high rates of trauma, such as urban areas with significant motor vehicle accidents or regions with high levels of interpersonal violence. Iatrogenic ureteral injuries, including avulsions, have been reported in roughly 0.52% of pelvic surgeries. This percentage increases with more complex surgical procedures like radical hysterectomies or colectomies. The signs and symptoms of ureteral avulsion can be variable and often depend on the severity of the injury and the presence of other associated injuries. Common symptoms include flank pain, which is pain in the side of the abdomen or back, often radiating to the groin. Hematuria, or blood in the urine, is another frequent finding. Patients may also experience abdominal pain or tenderness. Nausea and vomiting occur due to pain and inflammation. In cases of significant urine leakage, patients may develop abdominal swelling or a palpable mass caused by the urinoma. Fever and signs of infection can arise if the leaked urine becomes infected. In trauma settings, the symptoms of ureteral avulsion may be masked by other injuries, making it crucial to maintain a high index of suspicion. Diagnosing ureteral avulsion requires a comprehensive approach, starting with a thorough medical history and physical examination. Imaging studies are essential. A CT urogram, which is a CT scan with intravenous contrast, is the gold standard for visualizing the urinary tract and identifying the site of ureteral disruption. This imaging can show the avulsion, the presence of hydronephrosis, and any extravasation or leakage of urine. A retrograde pyelogram, where contrast dye is injected directly into the ureter, can also be used to identify the site of injury, particularly if a CT urogram is inconclusive. Ultrasound may be useful in the initial assessment, particularly in trauma cases, to identify hydronephrosis or fluid collections. Cystoscopy, a procedure where a small camera is inserted into the bladder, can help assess the ureteral orifice, which might appear abnormal or absent if an avulsion has occurred at the ureterovesical junction. While ureteral avulsions aren't typically classified into specific types, they can be categorized based on the location of the avulsion. We might describe it as a ureteropelvic junction avulsion if it occurs where the ureter connects to the kidney. Alternatively, it could be a mid-ureteral avulsion if it happens along the length of the ureter. Lastly, it could be a ureterovesical junction avulsion if the tear occurs where the ureter connects to the bladder. Furthermore, the extent of the injury can be classified as complete if the ureter is completely detached, or partial if there's still some connection remaining. The treatment and management of ureteral avulsion depend on the severity and location of the injury, as well as the overall condition of the patient. The primary goals are to restore urinary tract continuity and prevent further kidney damage. Initial management focuses on stabilizing the patient and addressing any associated injuries. A nephrostomy tube, a tube inserted directly into the kidney to drain urine, may be placed to decompress the kidney and prevent further hydronephrosis. Definitive repair usually involves surgical intervention. Options include ureteral reimplantation, where the ureter is reattached to the bladder, ureterostomy, where the two ends of the ureter are sewn together, or a Bori flap, where a flap of bladder is used to bridge a gap in the ureter. In complex cases, a renal autotransplant, where the kidney is removed and re-implanted, or even a nephrectomy, removal of the kidney, may be necessary. Minimally invasive techniques, such as laparoscopy or robotic surgery, are increasingly being used for ureteral repair. Preventing ureteral avulsion primarily involves minimizing the risk of traumatic injuries. Safe driving practices, fall prevention measures, and violence prevention programs can all play a role. In surgical settings, meticulous surgical technique and careful dissection around the ureters are crucial to avoid iatrogenic injuries. Surgeons must be aware of the ureter's anatomical location and variations, especially in patients with prior surgeries or adhesions. During ureteroscopy, gentle manipulation of instruments and careful attention to the ureteral wall can help prevent avulsions. The prognosis for ureteral avulsion depends on several factors, including the promptness of diagnosis and treatment, the severity of the injury, and the presence of any associated injuries. Early diagnosis and timely surgical repair are essential for maximizing the chances of a good outcome. Potential complications include stricture formation at the site of repair, urine leakage, infection, and in severe cases, kidney loss. Recent research has focused on improving surgical techniques for ureteral repair, as well as developing new materials for ureteral reconstruction. Minimally invasive approaches are becoming more common, leading to shorter hospital stays and faster recovery times. Ongoing studies are investigating the long-term outcomes of different repair techniques and strategies for preventing complications. Thanks for watching.